So once again, thanks for Shiva and all the organizing committee allow me to be here again in the wonderful city of Chennai. So my job today in 8 minutes will be sharing with you the outlet VSD closure. So this is my disclosure. So you may know I just recently published that there's the classification of the VSD, and this is one of the classification of outlet VSD. To be honest with you, I don't use that, but just to show you that how do they classify. So they talk about the malaligned without malalignment and also the posterior malalignment. Just just for the short brief assessment, that VSD can be inlet or the perimeter extension or even purely outlet, the outlet VSD like that. And the difference between this one and that one will be, as you can see here, the conduction system will be approximate to the rim if it's go closely to the perimeter area. But if it's away in between the septal marginalis like that, it will be totally away from the conduction system, but it will be mainly close to the aorta and also pulmonary artery. So this is what I will try to address today. So I think it's quite similar to other part of the world that having the outlet VSD or supplement VSD is about, in Asia, sorry, not partly of the world. In Asia, about like 20%, and the risk of aortic valve prolapse in at least in my country, it's about almost 90% in the patient beyond before 3 years of age. And this is a wonderful review from Dr. Thanarat, my boss, in Children's Hospital in Thailand, in Bangkok. So what will surgeon do to close the VSD? Definitely, the surgeon will try to close it from the right ventricular side, and the key is he will use the patch to stop the flow and also give the support to the aortic valve cuts. And they did very nicely job, because 2 years follow up, there is no progression of the AR at all. So if we're gonna do treatment by this outlet VSD, so we have to address at least aim for the same thing. We need to aim to close the defect and also to support the aortic valve cuts with our device. And you can appreciate that this is not all the cases doable. So that's why we need to select the case. So in terms of case selection, I will use so-called the TIN criteria, because he is probably one of the most experienced person in the world closing this kind of defect. So he just taught me that, okay, we just go for the bare body weight more than 10 kilo, and no severe AVP, and no moderate to severe AR definitely, and true defect should be less than 7 millimeter, and no other cardiac anomalies. What did he say about AVP? AVP, in his definition, if it's severe, it means that the distance between this, A to C, should be more than from C to B. So with that, he defined its severe aortic valve prolapse. And this is one of the example that he just gave me. Thanks for him, showing that the valve is quite prolapsing, and also not having the AR obviously, but the valve is quite collapsing. So with that, we need to really check very carefully about the echo, because that's very important thing. So normally, if you can appreciate that, the flow between systole and diastole is quite different. So we need to measure the flow during the end systole, and that will give you a little bit more of information whether what size should be the proper size. GAE can also sometimes help, especially for if you have like something like 3D imaging. You can see that, appreciate that when the heart is not moving, diastole, the valve is collapsing, and then when the heart is moving in systole, the valve is like protruding like that. So it's kind of Venturi effect. So with that, you can appreciate that dealing with this type of defect, you sometimes you can't just rely on the echo imaging only. You need to also have a good LV angio. And as you can see here, in order to delineate the anatomy on the outlet VSD clearly, you need even steep LAO, something over 90 degree or even sometimes even 110 degree, in order to delineate the anatomy very, very properly. And with that, you need to measure it, the diameter as usual, But just to show you that when we measure the diameter, if you measure just the flow, you may mislead because really because of prolapsing, and that causing the holes getting smaller. So with that, as a routine for all the cases, if we're going to do the VSD closure of the outlet VSD, we need to put the sheet in the contrast with the left ventricle in order to make sure that you properly size the defect. Otherwise, you run the risk of device embolization. In terms of device selection, definitely we cannot use a single disc device because it's so stiff, and also it's not support to the anatomy very well. But what we have to use, if we're going to close it, we need to prefer the double disc device or coil. And that's the reason, because it's more gentle. And as you can see, at least, showing very clearly that that kind of gentle device can dancing with the aortic valve most of the time, even if. So to choose the size of the device, you need to choose the size that fits to the true defect. True defects mean when the sheath is crossing, and then you do angio, and then you oversize just 1 or 2 millimeter above that diameter. So Tin also suggests that if we consider about the LV disc, you need to at least have 4 millimeter, not more than that, too much, at least 4 millimeter bigger than the VSD diameter. And here's some example of using the variety of the device in order to close the defect at the outlet part. So you can see here all of the device gonna dance with the aortic valve when it's moved. So that's kind of unavoidable character. And also, even if in small child, sometimes if you have to you can use that double disc device very nicely in small children. For the other double disc or the hybrid devices, I don't have much experience, so I won't go for that. In terms of approach to the outlet VSD, as usual for me, I will just use a cut pigtail just to guide my catheter, and sometimes you may use the straight tip catheter rather than the J tip catheter. But as you can see here, once it's jumped into the defect, it will go immediately towards the pulmonary artery. But also you can use the approach from the pulmonary artery. You can just slightly pull back as previously seen from the last patient, but not very much difficult in terms of the crossing by using that techniques. And after that, you need to also think about how to deploy it. Just to show you this patient, very nice demonstration that once this patient, I started to deploy the device from the left ventricular side first, and using the JR catheter, and this actually was the ADO2 6x4. So it looks fine immediately, and it looks okay, but just a few seconds, the device is fly away. And that's, because of the, as I said, that the tension of the cable and the catheter just pull the device back to the right ventricle. So I try again, didn't work very well. So I think I just go for the retrograde approach, and this is how it looks when we do retrograde approach. And it sits very nicely without any problem, and it stays until now, more than 2 years. So the outcomes, so in my opinion, to be honest with you, I'm not very big fan on this to close this defect. But in our experience, which is quite limited, we had one patient with mild MR, and we didn't have any problem on that in terms of the long-term follow-up. I mean, during at least 1 year follow-up. So Dr. Tin, he just gave me this information, 88 cases, having very good result immediately, and also no progression of the AR. So in conclusion, ladies and gentlemen, for the outlet VSD closure, I will ask you that be obsessed with patient selection, and be obsessed with the parents and patient education, because this is lifetime follow-up, and you be careful because you need a lot of inventory, and also you need the skill, and also your team should support, and make sure that whatever you do, you have to provide the results that your surgeon can give to the patient. So that's all I can say to you. Thank you very much indeed.
So any questions for this, for Dr. Worakan? I think Dr. Worakan, thank you for an excellent lecture on outlet VSD.
Thank you.
Thank you.
Thank you.
Yeah.
Thank you. My pleasure.